Hi, my name is Erin Greenler, and I'm a physical therapist at Massachusetts General Hospital in Boston. I'm here today with my colleagues Janice Strom, Megan Costello, and Eileen Gillen to present our poster. First, I want to thank Heather Hayes and the ANPT Stroke SIG for recognition of the best poster in stroke-related content at the ANPT Annual Conference in Minneapolis, Minnesota. Our poster is titled Functional Ambulation Category in Acute Stroke Predicts Disability at 3 months, and I'm excited to share our findings. This poster is part of the MGH SMART study out of the Lab for Translational Neurorecovery and Neurotechnology. SMART stands for Stroke Motor Rehabilitation and Recovery Study. It is an observational interdisciplinary research study of motor recovery after stroke, which collects rehab-focused outcomes starting in the acute stroke hospitalization at MGH and continuing over time across the post-acute care continuum. We know that the inability to ambulate independently is a key contributor to disability after stroke. However, in the acute care setting, including the ICU, there are many challenges which may limit assessment of functional ambulation, including gait speed. Our aims were to determine if using an alternative measure, such as the Functional Ambulation Category, or FAC, in the acute care setting, could predict functional outcomes at 3 months. Additionally, we wanted to assess if there was a relationship between FAC and gait speed.
The FAC is an observational measure of functional ambulation and has been recommended and validated as a tool for use in the stroke population, both prospectively and also retrospectively. We did a retrospective assessment in this study. The FAC categorizes walking ability into 5 groups, ranging from dependence to the ability to walk outside independently. To highlight scoring differences further, a score of 1 indicates a person is able to walk, however needs constant assistance to support body weight, maintain balance, or assist with coordination. In a score of 2, the person is able to ambulate, is also needing assistance of 1 person, but for intermittent or continuous light touch, more consistent with a contact guard assistance. Our study included 128 individuals with ischemic stroke who were ambulatory pre-stroke and enrolled in the Stroke Motor Rehabilitation and Recovery Study. Participants were evaluated acutely post-stroke with a range of 2 to 5 days post-onset of their stroke. For inclusion in the SMART study, eligible subjects were between the ages of 18 and 90, admitted to the MGH neurology service with upper extremity motor weakness after ischemic or hemorrhagic stroke, and could follow simple commands in English as required to engage in testing. Subjects with a history of developmental, neurologic, or major psychiatric disorder resulting in a functional disability, or with history of visual or auditory disorders limiting ability to participate in testing were excluded. In order for a participant to be eligible to participate in the gait speed testing portion of the SMART study, the individuals needed to be able to ambulate with minimum assistance or less. Though this criteria minimized the risk for greater hands-on assistance influencing the measured gait speed, it did result in the exclusion of a substantial number of possible participants for gait speed testing. The FAC was rated retrospectively by experienced acute care physical therapists through review of physical therapy notes during the acute stroke study period. Our participants were all evaluated between 1 to 7 days post-stroke. The modified Rankin scale, which describes an individual's degree of disability or dependence post-stroke, was assessed at 3 months by trained examiners. For analysis, the modified Rankin scale was dichotomized as good with a score of 0 to 2 or poor with a score of 3 to 6. The association between acute care FAC and 3 months post-stroke modified Rankin scale was analyzed using logistic regression. Baseline variables demonstrating a significant association with the predictor or FAC or modified Rankin scale.
Here you can see the distribution of participants with a good outcome or modified Rankin of 0 to 2 in gray, and those with a poor outcome or modified Rankin of 3 to 6 in red, broken down by FAC rating along the x-axis. An unadjusted logistic regression showed that a FAC score of 0 was a strong predictor of poor outcome relative to FAC of 5, which was statistically significant. After adjusting for covariance, the FAC remained a significant predictor of poor outcome. The other thing I would like to point out on this slide is a large number of participants that scored an FAC of 0 or were non-ambulatory, who by definition were not eligible for gait speed testing. We also noted a strong relationship between FAC and gait speed, as seen in this graph. However, as I just mentioned, over half of our participants were non-ambulatory. Though gait speed has been strongly associated with outcomes and return to community level activity, gait speed is not always possible, feasible, or safe to assess in the acute care setting. But FAC may be used in the acute care setting on all patients post-stroke to predict outcomes at 3 months.
Given the challenges of capturing gait speed in acute stroke, the FAC, perhaps alongside other existing prognosticating measures like the TWIST algorithm, may have greater clinical utility in the acute setting for categorizing ambulatory ability and predicting disability at 3 months compared to traditional gait speed measurements. The FAC is easy to use and does not require formal training for physical therapists. It is a measure that can be used within the first week post-stroke, including in the ICU, and is appropriate for use with non-ambulatory patients. As you saw in the results section, many of our participants scored a 0 on the FAC. Future research could explore the discriminatory factors relevant for recovery in this severe population and use these to develop prognostic algorithms for clinical use. Thank you so much for tuning in to learn more. We hope you enjoyed our poster.